Okay, let's unpack this topic. We're diving deep today into Epstein-Barr virus, or EBV,
Right, the virus behind infectious mononucleosis.
glandular fever, or maybe more familiarly, the kissing disease.
That's the one.
So you've shared a whole stack of notes on EBV, and our mission, really, is to take all that information
hmm
and turn it into a high-yield, easy-to-remember guide for you, the listener.
Yeah, think of it like us sorting through your revision notes together,
Yeah.
pulling out the really important bits, connecting the dots.
Making sure the key facts actually stick.
Exactly. Because EBV is, it's incredibly common. But understanding the full picture, from how you get it to some surprising long-term links, that's crucial.
Absolutely. So we're going to move through this material section by section, kind of like how your notes lay it out.
But hopefully with more of a conversational flow, something that makes it resonate a bit more.
Right. Our goal is that by the end of this deep dive, you'll feel, well, pretty solid on EBV.
We'll cover the works, what it is, how it spreads, who's most at risk, what's actually happening inside your body.
How doctors figure it out, what else it might look like.
Yeah, the differentials, how it's managed, and then, the prognosis and potential complications. It's quite a story for one virus.
It really is. And maybe a good place to start is what it actually looks like. The clinical features, the signs and symptoms someone might show up with.
Okay, yeah. Well, first off, the incubation period is pretty long. Typically 4 to 8 weeks between getting infected and maybe feeling sick.
4 to 8 weeks. Wow.
Yeah. And here's a really key point. A lot of people who get infected with EBV, they have no symptoms at all.
Ah, okay.
Or maybe just really mild ones they barely notice, like a cold or something.
So infection doesn't automatically mean you get the full-blown disease?
Not at all.
Mm-hmm.
But for those who do develop symptomatic infectious mononucleosis,
That's when you see the classic stuff.
that's right. The typical picture is quite distinct.
Yeah.
You often see really significant fatigue. That's a big one.
Mm.
A sore throat, which would be pretty severe.
Yeah.
Fever, and really noticeable swollen lymph nodes, especially in the neck. Sometimes the spleen can get enlarged too.
And the material you shared, it highlights a classic triad, right? Something that shows up in almost everyone who actually gets sick with IM.
Yes, this is super important clinically, a real high-yield point. If you see someone, particularly a teenager or young adult,
Right.
coming in with a sore throat,
Yeah.
lymphadenopathy, that's just the medical term for swollen lymph nodes and a fever.
You should be thinking mono.
You absolutely should. That classic triad, it's present in something like 98% of symptomatic cases.
Okay, sore throat, swollen nodes, fever. Got it. What other things might pop up?
Well, you can also get just general malaise, feeling really wiped out, headache, sometimes these tiny red spots on the roof of the mouth called palatal petechiae. And the virus can cause some mild inflammation in the liver. So you might see slightly elevated liver enzymes on blood tests. And changes in the blood count too, like an increase in lymphocytes, a type of white blood cell. Rarely, maybe some mild hemolytic anemia.
And there's a really specific rash mentioned. This feels like one of those key details for exams or practice.
Oh, absolutely critical point, especially in practice. If someone has EBV and they're mistakenly given certain antibiotics.
Like if someone thinks it's strep throat.
Exactly. Particularly, it can be really debilitating for patients. And it's worth noting, too, older adults, they might present a bit differently. Sometimes milder initial symptoms, but maybe things like liver or spleen enlargement are more obvious if they do get sick.
Okay, so now we have a picture of what it looks like. Let's maybe rewind a bit. What exactly is this virus? How do people get it in the first place? Definition and etiology.
Right. So at its core, Epstein-Barr virus is it's a member of the herpesvirus family. Human herpesvirus 4, technically.
Oh, herpes virus.
And while EBV is the main cause of infectious mononucleosis, responsible for 80–90% of cases,
Yeah.
your notes rightly point out that other infections can cause a very similar set of symptoms, an IM-like syndrome.
Like what sort of things?
Things like cytomegalovirus or CMV, human herpesvirus 6, toxoplasmosis. Even acute HIV infection or adenovirus can sometimes look a lot like mono initially.
So EBV is the usual suspect for the kissing disease, but it's not the only possibility if someone has those symptoms.
Precisely. You need to keep those differentials in mind.
And speaking of the kissing disease, how is it actually transmitted? Is it really just kissing?
Well, that's the main way. Primarily through direct contact with infected saliva.
Okay.
So kissing is definitely classic. But it also spreads easily by sharing drinks, utensils, maybe toothbrushes, Basically anything involving that saliva exchange.
Makes sense.
Less commonly, it can be transmitted through blood transfusions or organ transplants, but saliva is overwhelmingly the main route.
Okay, clear enough. Given that, who's most likely to get it, or at least get sick from it? The risk factors.
Yeah, the risk factors tie right back to how it spreads and how our bodies react.
Uh,
Obviously, close contact with someone who's infected, especially through saliva.
Kissing, sharing things.
Right, that's a major one.
So, teenagers and young adults.
Exactly, which links straight to another big risk factor, adolescence or young adulthood itself. That 15 to 24-year-old age group is where we see the peak incidence of clinical infectious mononucleosis.
Interesting. Why then specifically?
We'll touch on epidemiology later, but it relates to when people tend to get their first exposure in developed countries. Also, having a weakened immune system obviously increases your risk of potentially more severe or prolonged infection.
Okay. Let's dive a bit deeper now into what's actually happening inside the body. This sounds like where it gets really interesting. Pathophysiology. How does the virus work?
So it typically starts its journey by infecting epithelial cells, especially in the oropharynx, the throat area.
Right.
From there, it spreads and infects a key type of immune cell, B lymphocytes. These are crucial white blood cells.
And what does it do in those B cells?
This is where it gets clever. EBV establishes what we call a latent infection within these B cells.
Yeah.
It basically goes into hiding there, integrating itself.
So it just sits there quietly?
For the most part, yes, in latency. But it can still shed virus from those epithelial cells in the throat, even if the person feels fine. That's how it keeps spreading.
Sneaky.
Very. And establishing latency in B cells is a key way. It avoids being completely wiped out by the immune system.
So the symptoms we talked about earlier, the fever, the swollen glands, the fatigue, is that the virus directly causing damage, or?
It's mostly the body's response to the virus.
Ah, okay.
The classic symptoms of mono are largely driven by the immune system kicking into high gear. It activates lots of lymphocytes, including T cells trying to control the infected B cells. These activated lymphocytes flood into tissues.
Causing the swelling.
Exactly. Causing the lymph node enlargement, the spleen, swelling, that sort of thing. It's the immune battle, more so than direct viral destruction, that causes most of the symptoms you feel.
Fascinating. Okay, let's zoom out again. The big picture numbers. Epidemiology. How common is this thing, really?
Oh, it's incredibly widespread.
Bruh.
Globally, it's estimated that over 95% of adults have been infected with EBV at some point.
95%. That's almost everyone.
Pretty much.
Hmm.
Often people get infected in childhood and have few or no symptoms, so they never even know it. In places like the UK, infection is very common during childhood or adolescence.
But you said earlier the peak for actual sickness, for clinical IM, is in young adults.
That's right. While almost everyone gets infected eventually, symptomatic glandular fever is most common in that 15 to 24 age bracket.
Why the difference?
Well, in developing countries, exposure often happens very early in childhood when the immune response tends to be less dramatic, so it's often asymptomatic.
Okay.
In more developed countries, first exposure is often delayed until the teenage years or young adulthood. And when you get infected for the first time then, your immune system might mount a more vigorous and therefore more symptomatic response.
That makes sense.
The notes mention an overall annual incidence rate for symptomatic IM around 5 cases per 1,000 people. And you definitely see higher rates where young adults are in close quarters, think college dorms, military barracks.
Right. And infants are less likely to get sick from it?
Usually, yes, partly because they might still have some protective antibodies passed on from their mother. And interestingly, there's no real seasonal pattern to it or difference between genders in who gets infected.
So takeaway is almost universal infection, but symptomatic kissing disease peaks in young adulthood due to delayed first exposure in certain populations.
You've got it.
Okay, so let's say you've got someone, maybe a 19-year-old. They come in with that classic triad, really sore throat, swollen glands, fever.
Yeah.
How do you actually confirm it's EBV? What investigations do you run?
Right. Diagnosis relies heavily on blood tests. The main tools are serological testing, looking for specific antibodies against EBV,
Okay.
and a complete blood count, the CBC, to look at the different types of white blood cells, especially lymphocytes.
The notes you shared had some really useful age-specific guidance for testing. That feels like a key revision point.
It really is. Very practical. For children under 12, and also for people who are immunocompromised, the usual advice is to go straight for the specific EBV antibody tests, the serology, after about a week of symptoms.
Okay, under 12 or immunocompromised go straight to specific antibodies.
Correct. But for otherwise healthy people aged 12 and over, you typically start with a full blood count, FBC, same as CBC, and a monospot test.
When should you do the monospot?
Ideally in the second week of symptoms. That's when it's more likely to be positive if it's going to be.
Right. Tell me more about this monospot test. What's it actually detecting?
So the monospot test looks for something called heterophile antibodies. These are antibodies the body produces in response to EBV infection in maybe 70–90% of cases in adults and older children.
Heterophile antibodies, okay.
It's a relatively quick and simple test. But, and this is crucial, you need to know its limitations.
Which are?
Well, false positives are rare, which is good,
Mm-hmm.
but false negatives are quite common, especially if you do the test too early in the illness.
Why is that?
Because it takes time for those heterophile antibody levels to rise high enough to be detected. They typically increase over the first 6 weeks or so. So if you do a monospot in the first week and it's negative, but you still really suspect mono,
You might need to repeat it.
exactly, repeat it maybe 5 to 7 days later. Or consider the specific EBV antibodies. It's also less reliable in younger children, which is another reason for the age-specific guidance.
Okay, so what if the monospot stays negative after, say, 6 weeks, but the person still clearly has symptoms of mono?
That's when the EBV-specific antibody tests become essential. These are more targeted. They can tell you if it's a recent current infection or an old past infection.
How do they do that?
They look for different types of antibodies.
Yeah.
For instance, VCA-IgM antibodies usually indicate a recent or current infection. They rise early and then fade.
Okay. VCA-IgM for recent.
Right. Then there are eBNA antibodies. These appear much later, usually 6 to 8 weeks after symptoms start, and they stick around for life, indicating a past infection.
Got it. VCA-IgM, recent EBNA, ILS past. That's useful. Any other tests that help?
Yeah, the full blood count, the FBC, is often very suggestive. You'll typically see a raised overall white blood cell count, driven by an increase in lymphocytes called lymphocytosis. And crucially, under the microscope, a significant proportion of these lymphocytes, often more than 20%, will look atypical. They look larger, kind of reactive.
Atypical lymphocytes. Okay.
You might also see a raised ESR, which is a general marker of inflammation. And those mild elevations in liver enzymes, we mentioned AST and ALT. So checking liver function tests, LFTs, is pretty standard.
What about things like PCR?
Sometimes, yeah. Real-time PCR can detect EBV DNA directly. It might be used if the diagnosis is really unclear, or perhaps in immunocompromised patients where antibody responses might be unusual.
And ruling out other things.
Yeah, definitely.
Yeah.
You might do throat swabs to check for bacterial causes like strep throat. And if you're worried about the spleen being enlarged, an abdominal ultrasound can give you a clear picture of its size.
So putting it all together, the diagnosis usually involves the clinical picture, especially that triad.
Right. Sore throat, fever, swollen glands.
Combined with the blood tests, FBC, LFTs, and then either the monospot or specific EBV serology, depending on age and timing.
That's the standard approach, exactly.
This brings up a really important question, though. If someone comes in with those symptoms, particularly the bad sore throat and fever, what else could it be? The differential diagnosis.
Yeah, this is absolutely critical in practice. You always have to think about other possibilities that can mimic mono.
What are the main ones to consider?
The big ones are definitely streptococcal pharyngitis, regular strep throat, other viral infections like cytomegalovirus, CMV, which can cause a very similar picture. Acute HIV infection, especially early on, can present with mono-like symptoms, and toxoplasmosis.
Okay, strep, CMV, HIV, toxo. How do you start telling them apart?
Well, strep throat often has that really prominent pus on the tonsils, the exudate, but EBV can cause that too. So a throat swab, specifically for strep bacteria, is often helpful.
Right.
Your notes mention a couple of other specific clues, like swelling around both eyes, bilateral periorbital edema. That's not typical for EBV and should make you think about other causes, maybe allergies, or even something like Kawasaki disease in kids.
Okay. And what about the swollen lymph nodes? Could they point to something more serious?
Absolutely. While widespread swollen glands are classic EBV, if they're unusually large, hard, fixed, or asymmetrical, you have to consider more serious conditions.
Yeah.
Things like leukemia, lymphoma, or even head and neck cancers metastasizing to the nodes. That's where looking closely at the blood film is important. Are these just atypical reactive lymphocytes fighting an infection, or are they truly abnormal, potentially malignant cells?
A crucial distinction. We mentioned liver enzymes earlier. What if they're really sky high, not just mildly elevated?
Yeah, mild LFT bumps are common with EBV.
Yeah.
But if they're significantly deranged, you absolutely have to broaden your investigation, rule out other causes, hepatitis, viral hepatitis A, B, C, alcohol, drug reactions, and so on.
Makes sense. And what if the monospot test is negative?
Right. That brings us to heterophile negative infectious mononucleosis. If someone looks like they have mono, but the monospot is negative.
You think about those other bugs.
Exactly. You think strongly about CMV, acute HIV, toxoplasmosis, rubella, adenovirus, all those things that can cause an IM-like illness, but won't trigger the heterophile antibodies that monospot detects. This is where the specific EBV antibody tests, VCA, IgM, EBNA, become really crucial to confirm or rule out recent EBV.
Okay. And your notes also list several quite serious diseases that EBV itself is associated with, potentially long after the initial infection is over.
Yes, and this is a really fascinating and important area. EBV infection has been definitively linked to several types of cancer.
Such as?
Certain types of lymphoma, like Burkitt's lymphoma, particularly in Africa, and Hodgkin's lymphoma, also B-cell lymphomas that can arise in people who are immunosuppressed,
Yes.
like transplant recipients or those with HIV.
Wow. Any others?
It's also strongly linked to nasopharyngeal carcinoma, which is more common in certain parts of Asia, and some types of salivary gland cancer. There's also Duncan syndrome, which is a rare genetic condition where EBV infection triggers a severe, often fatal immune overreaction and lymphoma development.
That's quite a list. And the notes also mention multiple sclerosis?
Yes, there's growing evidence suggesting a strong association between EBV infection and the later development of multiple sclerosis, MS-BAC. The exact relationship is still being worked out, but it's a significant link.
That's really surprising. Okay, so let's shift gears. You've figured out it is EBV, or you strongly suspect it. What do you actually do for the patient? What's the management?
The management is, honestly, almost entirely supportive care.
Supportive care, meaning?
Meaning there's no specific cure, no magic bullet antiviral drug for routine infectious mononucleosis. The main focus is just on helping the patient feel better while their own immune system deals with the virus.
So what does that involve in practice?
Rest is really important. The fatigue can be profound, so encouraging patients to take it easy is key. Staying well hydrated, especially if they have a sore throat that makes swallowing painful.
Fluids, yeah, pain relief.
Definitely. Simple over-the-counter pain relievers like paracetamol or ibuprofen can help manage the fever, the sore throat, and any muscle aches.
Okay. Are there any really crucial things people need to avoid doing? This sounds important.
Absolutely, yes. These are probably the most critical management points. Number one, avoid contact sports and strenuous physical activity.
Why is that?
Because of the risk of splenic rupture. The spleen often gets enlarged and a bit fragile during mono, and a blow to the abdomen could potentially cause it to rupture, which is a medical emergency.
How long should they avoid sports?
Guidelines vary a bit, but generally it's recommended to avoid contact sports for at least 3 to 4 weeks after symptoms start, and sometimes longer, especially if an ultrasound confirms the spleen is still enlarged. Needs individual assessment.
Okay, no contact sports. What else?
Avoid alcohol while acutely unwell. The liver can be mildly inflamed, so it's best not to put extra stress on it.
Right.
And, as we hammered home earlier, avoid giving ampicillin or amoxicillin. Because of that characteristic rash it causes in EBV patients.
Got it. Avoid contact sports, avoid alcohol, avoid ampicillin, amoxicillin.
So no specific antivirals like aciclovir that work for other herpes viruses.
No. While drugs like acyclovir or valacyclovir are active against EBV in a test tube, clinical trials in people with typical IM haven't really shown convincing benefits in shortening the illness or reducing severity, so they're not routinely recommended. What about steroids? Sometimes used for bad sore throats.
Generally, no. Steroids might be considered in very specific severe complications, like impending airway obstruction from massive tonsil swelling, but they aren't recommended just for routine symptom control in uncomplicated mono. There are concerns about potential side effects.
And antibiotics? We know they don't work for the virus itself.
Correct. Antibiotics are completely ineffective against EBV because it's a virus. They should only be used if there's clear evidence of a secondary bacterial infection on top of the mono, like a confirmed bacterial strep throat happening at the same time.
When might someone actually need to be admitted to hospital?
It's usually not necessary, but admission might be needed if someone becomes severely dehydrated because they can't swallow enough fluids. They might need IV fluids. Or in those rare cases of extreme tonsillar swelling threatening the airway.
And splenic rupture.
Oh, absolutely. That's an emergency requiring immediate hospital care.
Oh.
It might need surgery, although sometimes non-operative management is possible depending on the specifics.
Your notes also mention vitamin D supplementation.
Yeah, just as a suggestion, possibly to aid recovery, but it's not a standard mandatory treatment, more of an area of interest.
So, bottom line for management: rest, fluids, simple pain relief, and those really important avoidances.
That's the heart of it for uncomplicated IM, yes.
Okay, let's wrap this up by looking ahead. What's the usual outcome, and what are the potential bumps in the road? Prognosis and complications.
So the prognosis for most people with infectious mononucleosis is generally very good. Most individuals recover fully within, say, a few weeks to a couple of months.
But the fatigue can linger.
That's the main thing, yes. That fatigue and malaise can be quite persistent, sometimes lasting for several months after the acute symptoms like fever and sore throat have gone. That can really impact school, work, daily life.
And does the virus actually leave your system once you recover?
No, and this is a really fundamental point about EBV, like other herpes viruses. Once you're infected, EBV establishes a lifelong latent infection. It stays dormant in your body, mainly within those B lymphocytes we talked about.
Forever.
Forever. Your immune system generally keeps it well under control, but it never completely eliminates it.
Can it come back?
It can reactivate, especially if the person becomes immunocompromised later in life due to illness, medications, etc. This reactivation is often asymptomatic. You wouldn't know what's happening, but the person might shed virus in their saliva again, potentially spreading it.
Okay, lifelong latency with potential reactivation. What about those complications? You mentioned splenic rupture, but the notes list others. They sound serious, even if uncommon.
They are uncommon, definitely, but important to be aware of. Splenic rupture is probably the most acutely feared one, hence the advice about sports.
Right.
Other potential complications, though rare, can include hepatitis more severe than the usual mild liver inflammation. Neurological problems can occur, things like Guillain-Barré syndrome,
Which affects the nerves.
yes, causing weakness and paralysis,
Yeah.
or Bell's palsy, facial nerve paralysis. Encephalitis or meningitis are also rare possibilities. You can also get secondary bacterial infections, like we discussed, a bacterial tonsillitis on top of the viral one. And very rarely, that extreme tonsillar enlargement can actually threaten the airway, requiring urgent intervention.
Any heart or blood issues.
Rare cardiac abnormalities like myocarditis or pericarditis have been reported. Hematologically, you can sometimes see more significant hemolytic anemia or thrombocytopenia, low platelets.
Kidneys.
Also rare, but kidney problems like acute interstitial nephritis or glomerulonephitis are listed as potential complications. And beyond the physical, that prolonged fatigue can sometimes contribute to developing depression.
And finally, just to reiterate those long-term associations we touched on earlier, there are essentially very serious potential complications too, right?
Absolutely. Those malignancies are the most concerning long-term risks linked to EBV. Burkitt's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, and certain lymphomas in immunocompromised individuals like HIV-associated CNS lymphomas.
And there was one other non-cancerous one.
Yes, oral hairy leukoplakia. It's a white lesion typically seen on the side of the tongue, strongly associated with EBV, usually occurring in people with weakened immune systems, particularly HIV.
Man, it really is remarkable. You start with what's often a silent infection in childhood, or maybe a rough few weeks feeling awful as a teenager.
Yeah.
And this virus just sets up shop for life. And while most people are fine, it carries these potential links to a whole spectrum of conditions, from fatigue right through to rare neurological issues and even cancers decades later.
It really highlights the incredibly complex and sometimes precarious relationship we have with these common viruses that live within us. It's definitely more than just the kissing disease.
Well, we've taken that listener stack of notes and hopefully turned it into a really dynamic, high-yield deep dive into Epstein-Barr virus. We've covered the ground from what it is and how you get it, right through the symptoms, the diagnosis, the management do's and don'ts, and this surprising list of potential complications and associations.
Hopefully hitting those key points, the triad, the ampicillin rash, the age-specific testing, the crucial avoidances, helps make it all stick.
Yeah, making those connections is what it's all about for revision.
Exactly. Understanding the why behind the facts.
And maybe a final thought to leave you with. What's truly fascinating here, I think, is how this almost universally acquired virus, often caught without us even knowing, manages to persist for a lifetime. and how that persistence underlies such a diverse range of potential outcomes, from nothing at all to chronic fatigue to rare but devastating diseases. It really speaks volumes about the intricate dance between a virus and its host.
Definitely something to keep pondering as you continue your studies.
If you found this deep dive into EBV useful for your revision, or maybe just for your own medical curiosity, you can find much more high-yield medical revision content just like this over at PassTheMSRA.com.
And don't forget, you can also find a load of great free resources to help with your studies at freemasray.com.
Thanks so much for joining us for this deep dive. Keep learning.